I'd like to thank Dr. Van Cutsem and Dr. Tabanero for asking me to discuss oxaliplatin this morning. And it's a pleasure to be here. I'd also like to compliment the florists. I think these are wonderful floral arrangements. They're much better than the ones we get at ASCO. So thank you again. In terms of disclosures, I consult as an advisor for a few companies, but I have no conflicts to disclose. I'd also like to wish everybody a happy Independence Day. The picture at the bottom here is the Minuteman statue, which is in Westport, Connecticut. That's about a mile and a half from my house. That's where the British tried to invade Connecticut in 1777 and were repelled by the colonials. And so, again, happy Independence Day. So my first reaction to this is a very retro discussion. Dr. Dwyer started out by showing all these studies from 2004, and in fact we had this debate in 2004 where people were debating what's the best regimen, FOLFOX or FOLFIRI. So I'm not sure we need to relive that, and thanks to Dan Sargent and Axel Grothe, we can see that the conclusion of this was the best approach was really to use all three drugs. And when you gave all three drugs, it really didn't matter which the first line regimen was. The main thing was that the correlation for survival was based on the fact that patients were exposed to all three drugs. And I think that was the takeaway message in 2005. So then we ended up doing a few more debates in 2008. Anti-angiogenesis, anti-EGF, maybe both, who knew? Somebody won, we're not sure. Hillary's coming back again. But why do I use FOLFOX? So I think modified FOLFOX is like our colleagues from the UK kind of quasar. It's quick, simple, and reliable. That's how I regard FOLFOX. It's very easy to combine with biologics. It has minimal GI toxicity. It's tolerated very well. We don't have the problems of continuous diarrhea and neutropenia like we saw in the IFL regimen. And I think that we've seen some data using cetuximab with depth of response, but personally I feel that with oxaliplatin there may be an advantage that way also. And then I'd just like to review some of the existing data for the use of first-line oxaliplatin. So I'd like to review the CAIRO3 data, the PRIME data, and then 80405 combined with FIRE3 for some more recent studies, not quite so retro. But I think this study, the CAIRO3 study, really shows us how to use oxaliplatin. The key thing, which many of us have discussed over the years, is the right way to use oxaliplatin in kind of an intermittent way or a stop-and-go approach with a maintenance approach. And you'll hear more about this from Dr. Grothe coming up. But in this study, you used CAPOX for 6 cycles of induction, and then the randomization was to maintenance or not, and reintroduction of CAPOX. So there was PFS1 for the maintenance, and then PFS2 for reintroduction. And you can see here that clearly maintenance is helpful, which is going to be another discussion. But for PFS2, if you reintroduce oxaliplatin and use it kind of in a stop-and-go approach where you control the neurotoxicity and you reintroduce it, patients do very well. And there was a benefit in terms of using the maintenance and reintroducing. And then even if you didn't reintroduce but switched to FOLFIRI, this was the time to treatment to progression. The hazard ratio was quite good, and the borderline was there was a borderline benefit for survival even using this kind of approach. So the key thing with oxaliplatin is not to use it continuously, but to use kind of an intermittent and a maintenance strategy. So I think that was the problem with the 966 study that you already heard from Dr. Dwyer, is that in that study pretty much everybody stopped at 6 months. They didn't reintroduce oxaliplatin. That was a problem. One other example of using FOLFOX as first line is in this study, the PRIME study with panitumumab. As many of you remember, the study originally started out including patients who had KRAS mutation as well, and then eventually accrued more patients with wild-type KRAS only, and it was and it was powered for the wild-type KRAS group. And you can see here the hazard ratio when you added cetuximab was 0.8, but it shows that you have a very good overall survival, and then the updated analysis using the more expanded RAS showed a hazard ratio of 0.78 for the extended RAS wild-type, again showing the benefit of this with a median survival of 26 months. So finally, comparing the more recent trials now, even though they aren't head-to-head of FOLFOX versus FOLFIRI, we can look at 80405 and FIRE3 to see how these these regimens are being used now in first-line therapy. So in this U.S. intergroup trial, and you will hear the update on this from Dr. Vanook coming up very shortly, but in the data that was presented last year at ASCO, for 1,140 RAS wild-type patients, you can see here now the overall survival for either biologic is around 29 to 30 months. So excellent overall survival. In this study, about 80% were FOLFOX. So it's mostly FOLFOX first-line chemotherapy in this U.S. study. And for the PFS, again, about 10.8 months. You can see here for the chemotherapy, mainly with the toxicity is again mainly controlled by the oxaliplatin, and you can see that it is quite acceptable, and there is really, other than neuropathy, that's the main toxicity. We can compare this to the FIRE3 trial, where we have 25 months for the FOLFIRI backbone with bevacizumab, and even though the hazard ratio was 0.77 and was adjusted later for the RAS wild type to even larger, the problem here isn't so much that the cetuximab is better, it's that the FOLFIRI is worse when you add bevacizumab. So if you look at the two curves compared to each other, you can see here that, I'm sorry if I go back, you can see here that the cetuximab arm in FIRE3 is the same as the 80405, but FOLFIRI with bevacizumab in the FIRE3 is an inferior arm with only 25 months median survival compared to 29 to 30 months in the two other arms, in the one arm and the two arms in the U.S. intergroup study. So if anything here, this shows that FOLFIRI plus bevacizumab may be an inferior arm compared to the other trials. So comparing 80405 and FIRE3, you can see here that 80405 was twice as large with an overall survival as the primary endpoint. It was mainly FOLFOX, and again, it shows that FOLFOX is very useful as a first-line regimen and gives us the best overall survival for any studies that have been published to date. So why use oxaliplatin as the preferred backbone? Unfortunately, there isn't much head-to-head data. I mean, it's kind of unfortunate that we have to go back to a small randomized phase 2 from Christoph Turnegand in 2004 to look for head-to-head comparisons, but again, we've kind of gotten past that argument. The FOLFOX as a backbone is tolerable. It has non-overlapping toxicity with the biologics. When you use it in a kind of stop-and-go or maintenance strategy, you have very good long-term outcomes using the Cairo-3 approach, which was then confirmed by 80405. And this is equally true for the RAS wild-type patients using anti-EGFR, as shown in the PRIME and the 80405 data. So again, thank you for the invitation to speak, and it was a pleasure talking to all of you today.